Well, hello and welcome to the inaugural episode of a brand new program called COVID Fact Fiction. I'm your host, Dr. Jason Deitch, and of course, I'm here with Dr. Chris Centeno, MD. Dr. Centeno, this is a project that I know you put a lot of time and energy into. This is a problem that affects us both nationally, of course, and globally. Your background is as a medical doctor, as a researcher, scientist, clinician, and you have been very excited to really bring this on the forefront. You've been very vocal about following the science, following the research, and continually doing the research that really helps all of us better understand, as the title explains, fact versus fiction. So thank you for doing this program. Let me just sort of open it up by asking you to share more about your background, your history, and what's really motivated you to take this project on.
Yeah, Jason, thanks. I started with all of this because as a physician, I was getting asked questions about COVID-19. And at the time, way back in March of 2020, I knew as much about COVID-19 as anybody. And so I started to do some research on my own. And being a medical researcher who's published a bunch of different papers and being a physician, obviously, I had the training to look at this stuff and understand it and try to figure out what was happening. And what was really surprising to me as I did that research was that I kept finding that I would see X was really happening and the media was saying it was Y. And that was really disturbing, actually. And I then got asked by Dan Bongino to come on his show, so that may be where you started following me if you're seeing this. And I just kept digging, and because that's what I love doing, is digging into things. So this show will be about sort of a midweek dig into what's happening in the media, and then what we'll do is you can expect a deep dive blog once a week. That'll be a longer read, more detail, diving into a specific subject. But this midweek video and podcast is going to be more just jumping around and digging into whatever is in the media at that point, because it changes so quickly that, really once a week, if you follow this and you're scratching your head saying, hey, does this make any sense? You're going to need that midweek decompress or debrief to really see what's happening.
And one of the things our viewers should know as we sort of launch this project is that this is a science-focused program. You will see things that may agree with some people on some networks, and disagree with others, and vice versa, as in this is not driven by a media-driven agenda. This is driven by really searching and researching what's going on based on the data. And one of the things I know that we're going to really sort of get into is really teaching people, exposing people to how to look at data, how to think about data, where to go for data, and how to give it meaning. Most of us, unfortunately, I'll say, are victims of the information that we limit our exposure to, whichever side of the aisle you may sit on. And this program is really about not following an agenda beyond what's fact, what's fiction, and ultimately, it'll be up to you, the viewer, to decide what's right for you. You want to expand on that a bit and sort of get into the science and what that really means to people?
Yeah, we follow the data here. So what that means is that when I read a headline, my assumption is the headline is incorrect until it's proven correct. And so I'd like to teach you how I think, how I do some investigation. So when you see this random headline and you read it and you're just incredulous, you're like, wow, is that right? You've got the tools to try to understand, is that right? And we will go where the data takes us. So it doesn't matter to me that the data might take us in a place that says that CNN is full of it, or Fox News is full of it, or the Epoch Times is full of it, or MSNBC is full of it. It doesn't really matter. The data goes where the data goes. And if there's a narrative that's going the opposite direction, I'm going to point it out regardless of who published the story.
That's the key here, and very much the motivation for doing this program. We have not seen many, if any, we haven't seen any ongoing series. We've seen a few people interview a few experts. You've seen them on different shows and so on. But a week later, oftentimes, we could know something completely different than what was told a week ago. So that's the point of this going on a regular basis, is to really stay current with what the data shows. And again, we're going to say it over and over again. We are not on one side or the other, nor will we really tolerate comments that promote one side or the other, obviously. We're searching for the data so that you can make the right decision for you. All right, Dr. Centeno, let's get into, you have some data you've looked at so far. We'll get into that. Are we ready to share a screen, or what do we got?
Yeah,
Take it from here.
let's
Okay,
share a screen here.
we're looking
One
at
in
it.
yeah, 1 in 3 young adults vulnerable to severe COVID-19, and smoking plays a big role. So I saw this. I'm a parent, right? Lots of us are parents, and or have young kids. Kids are a little older, young adults. But as a parent, I saw this and I was like, wow, this is really interesting. My sense is, knowing the data, that this headline itself doesn't make much sense. So then I go into the story, and basically this is a study by the University of California, San Francisco. They looked at 8,000 participants that were aged 18 to 25, and then they looked at some risk factors for severe COVID-19 and concluded that 1 in 3 of these young adults, again, ages 18 to 25, were at risk for severe COVID. Now, this one is really easy to debunk. And all you really need to do is to go to the CDC website, and you will find all of the data for deaths. So you'll be able to get a sense very quickly. So if we go to those ages of that they've got it listed as 15 to 24 years old. So in the 15 to 24-year-old range, we've only had 149 COVID deaths. That's out of 114,000 COVID deaths. And then if you go over to the next line, it says that to date, there have been almost 13,000, 12,958 deaths due to all causes. So it doesn't take much math to figure out that there's a 99% chance that if a kid dies of something this year, it's not going to be COVID. And that kids in that age range make up such a tiny percentage of the people who have died from COVID-19. So again, if I go back to this article, my overall sense is the average parent would read this and say, oh my God, I've got to take my kids away from other kids. I've got to shelter them in place in my house. I've got to make sure they never go to school again. They never go to the store, yada, yada, yada. But in fact, your kid is far more likely to die while texting while driving. In fact, about 100 to 1,000 times more likely, depending on the age of your kid, than COVID-19. So this earns what I call a panic porn award. This is panic porn. It's not really real. And obviously, this story should have come with all sorts of disclaimers, but it did not. Its goal was to garner eyeballs, and that's what it obviously garnered. But there isn't much accuracy or truth in reporting here. So it just earns a panic porn award. So what are your thoughts, Jason?
Crazy. I keep wondering why. Why the panic? What is the reason for getting people so, worked up? That does not mean that anybody's saying that there's not a reality to what's going on here. Clearly, there's a reality to it. But panic porn basically means that this is an excessive, perhaps I'll call it abuse, extreme version of instilling panic. I'm a parent too. You see that, and instantly you start going, well, maybe they shouldn't be going to school when there's so many benefits that they should. And again, the data is the data, and that's the point. This is not, a political perspective or a supportive of a particular candidate's perspective. The numbers are what the numbers are. You just pointed to the CDC's website itself. I guess, are there other websites with other data that would contradict this?
No, I mean, the CDC is the one that's tasked with putting all this together. You can obviously go to individual state websites, but the state website data is going to look very similar to this. I've looked at it many times. Listen, I think if anything, the CDC's data is overestimating COVID deaths because they're counting anyone who died with COVID. So, for instance, in our state of Colorado, what our governor requested was that they start separating out the data of died due to COVID versus died with COVID. Died with COVID means you died of whatever and you happen to have a positive COVID test, which is what we're seeing on the CDC website. Died of COVID is some doctor thought within a reasonable degree of medical certainty that COVID-19 is what killed you. And that could be due to your symptoms, that could be due to your hospital course, and obviously that almost always involves a positive test. So yeah, I think if anything, the CDC numbers are inflated.
That's an essential distinction that it's hard to just skip over and go and accept as normal. What I think I hear you saying is that much of the data that we are basing us, well, not we, but the media is basing its headlines on, is data that is important to understand that you just described. Dying with versus dying of, as in a child is in a car accident, happens to test positive. I've heard in some cases, even if that child might have been sick and there's a suspicion that they might have had COVID, that is enough to go on a certificate and count in the data. Is that accurate? Do you know?
Yeah, so as an example, when our governor made the switch, it reduced our COVID-19 deaths in the state of Colorado by 25%. So 25% of those deaths were clearly, the doctor did not believe that that person died of COVID. So as an example, in an outbreak in a nursing home where someone was in hospice care and it was going to die in the next week of a cancer diagnosis, and that person died and then happened to test positive for COVID. That was one of the things that was being backed out in the Colorado data. So yeah, I mean, things like that happen, but realize at the end of the day that there's a big difference. And I think what we all want to know is who died of COVID-19 versus who died with COVID-19.
And it's really difficult, as we've seen now over the months as this unfolds and the story continues. It's hard to make decisions. It's hard to make policy based on data that's not necessarily truly accurate. I mean, this with versus of debate, argument, approach is significant. I guess let me ask also to some degree, how do we know the accuracy of the tests when they're tested? How many of these data points have required a test in order to determine whether they should be a number in that column or not? Is testing a requirement, or is the doctor's judgment enough?
Yeah, it's a good question. Different states have it different ways. In New York, for example, the doctor saying that person died of COVID without a test is enough. And the state and the city, the state and New York City count it differently. So listen, it's a mess. And it's important to note that there are people on the other side of this argument who claim that lots and lots of people have died of COVID-19 when we didn't have the proper testing apparatus in place. Now, the good news is that's probably a relatively small number because it was early in the pandemic before we had widespread testing. We are now testing at a rate of more than 100,000 per million. And we're right up there. In fact, we've long since surpassed Germany's rate of testing. We've surpassed Canada's rate of testing. And we're right up there with many, many developed countries on the number of tests that are being done. And yes, those tests do have a false positive and a false negative rate. And you have to realize that the false negative rate goes way, way, way up when the prevalence is low. So the accuracy of any test when there's not a lot of disease out there is very, very poor. It doesn't matter if the accuracy is listed as 99%. If there's only a 1% prevalence of the disease, meaning there's only 1 out of 100 people that have it, the actual real accuracy of that test is very, very poor. Now, as more people get COVID, the accuracy of these tests will increase. And I know that's something hard to get your head around. That's a statistical thing. But it's important to know that in places like Wyoming, where there might only be 1 in 100, 2 in 100 people that have COVID, the accuracy of a test there is different than a place like New York City, where 1 in 4 will test positive for having had COVID-19.
I know you've got more data to get into. I'm going to throw this question out there if you want to get to the data or somehow. But one of the things I've always wondered and asked myself is, there's a talk about herd immunity. And there seems to be the concept, historically there's been the concept, that our goal is for us to reach a percentage, a level of people that have been exposed, that therefore have built the antibodies, so that collectively we all become less susceptible. So can you help us understand what seems to be a contradiction on that? On one hand, our goal is to reach this herd immunity, which can only be reached by more and more cases. So there's a positive reason, a positive intention for us to want this to get to more people so we can reach that goal of herd immunity, versus the panic of more and more and more cases as if it's a bad thing. How do you reconcile? On one hand, scientists are saying we need to reach herd immunity in order to get to the other side. And on the other hand, everybody's freaking out as we're actually racing to that goal. How do you reconcile that?
Yeah, so herd immunity, just that everyone knows, is when about 70% or so of everyone has the disease. So if the virus wants to jump from one person to another, there's a 7 in chance it's going to reach someone who can't propagate it, and the virus will die in that person. And then things start going down, and that's what herd immunity is all about. Now, what's interesting here is there are some that are just saying it's not possible with this disease. That's probably not true. There was just a vaccine trial that showed that building antibodies was more than possible with this disease. So it's likely that herd immunity would work. But you're right. You've got Sweden's approach, which is just to ask people to social distance, not close much down, ask people to wear masks, etc. And their death rate has been doing this, as I've covered, meaning it's been going way, way, way down, just like ours. In fact, ours is probably not as good right now. So you've got this issue of if you allow things to go their normal course, you're definitely going to see more deaths. But if you keep things shut down, the scientists have told us that just pushes the deaths down the road. So my thought has always been our real focus should be on keeping our healthcare systems from getting overloaded. If our healthcare systems get overloaded, nobody wins. We have a lot more people dying, rather than trying to stay shut down for long periods of time. Because the problem with staying shut down for long periods of time is that you're going to have deaths due to the shutdown. In fact, we'll probably have more deaths due to the shutdown than we will from COVID-19. For example, the American Academy of family physicians said that we will have about 150,000 deaths just due to despair, suicide, alcoholism, domestic violence, all of that stuff, if we stay shut down. And it looks like that's where we're headed. In addition to that, there are more deaths. There are people who have AFib and who are going to stroke out rather than wanting to go in and get an ablation done. So we're probably going to have several 100,000 more deaths related to being shut down. So you've got to look at that calculus, because at the end of the day, those numbers may be equal. If you just let this thing take its natural course, tell people to social distance, not shut down, versus the number of people you're going to lose by staying shut down. And that brings us actually to our next topic. Let's jump to that. This was an interesting story out of Fox News. And I'm not going to tell you I'm a Fox News fan or I'm a CNN fan or whatever it is, because there'll be times when I go after Fox News as well as CNN. But this was a broken heart syndrome. So you read that and you're like, what is broken heart syndrome? Is that a thing? Is it possible to die of a broken heart? And the answer is kind of. This is actually the study that was behind it. And it talks about something that's now well known called stress cardiomyopathy. So what is cardiomyopathy? Cardiomyopathy is your heart is a muscle. And like any muscle, it can atrophy. Obviously, your heart having atrophy is a really bad thing, right? It keeps you alive. So it's got to be a strong muscle, and you want to make sure it's a strong muscle. That's why it's recommended that you do cardio type workouts, et cetera, et cetera. Well, this is a study that talks about what's called stress cardiomyopathy, and that's when stress hormones and all the other stuff involved with stress actually damages the heart muscle. And so what these guys found was really, really interesting. The stress from the pandemic increased the incidence, that's the percentage or the prevalence, from about under 2% to about 8% of cardiomyopathy. So there's been a quadrupling of the number of people who have stress damage to their heart, presumably due to the pandemic. And so obviously this is something that's not being measured. So we've got our deaths due to despair, we've got our deaths due to stress-related causes, then we've got our deaths due to lack of medical care or being fearful to walk into the hospital. As an example, I talked to a healthcare executive this week. He tells me that all of his healthcare executive friends that run hospitals state that their volumes are down by 50%. Why are their volumes down by 50%? People are too afraid to go to the hospital right now because of what we have created. So it turns out that, dying of a stress-related heart condition that isn't a heart attack, it is a thing.
It's going to be fascinating to see how this all unfolds as we collect more and more data. And it is fascinating, obviously, we're thinking through both sides of the equation. There are those people that say, but life is precious and we've got to do everything we can to save lives. What's the difference, though, do you think, in this particular specific case, maybe at this particular time? Why are we so concerned about these types of deaths? And it just seems like we're ignoring other types of deaths. As you mentioned, suicide rates are up, as it's been reported, increases in alcoholism, increases in opioid addiction. There's decreases in car accidents, I've read. But why are we not looking at this in the context of, the cure potentially being worse than the actual disease?
Yeah, well, I think that obviously, listen, as we've talked about before, the media's job is to sell eyeballs. If you want to sell a maximum number of eyeballs, how you do that is you go with the sex appeal. And the sex appeal right now is obviously on the COVID-19 side. That's what gets you to look. But little studies like this, talking about a fourfold increase in this disease due to the pandemic, are not going to really make the mainstream media. It goes against that narrative that's out there. And at the end of the day, you're absolutely right. This is a balance scale. So it's like, that the little balance scale that you see where, let's say, the scales of justice, this side or that side. How many people will we lose to the pandemic versus how many people will we kill by the cure for the pandemic, which is the shutdown? And the answer is, again, my guess is after this is all over and after we can sit down for a few years and digest it, there will be papers that will be produced that say that it's probably a wash, that we probably killed as many people with the shutdown as we did through the pandemic. So that's the problem, is no one's looking at the balance, and that should be our job as doctors. And that should be the job of every public health official. The problem is, as a public health official, if you take that role right now and you start talking that way, you're going to be lambasted and destroyed on social media. You're going to probably lose your job position as a result of even having the gall to talk about the lost lives over here versus the lost lives over there.
It has become very easy for consumers who are, watching the mainstream media. It's their primary source of information. Oftentimes, people sort of tunnel themselves to one station or the other, or two stations and one other. But there tends to be obviously a very polarized perspective that people have, and judgments people make about these things, oftentimes very much based, I'll say exclusively on the headlines and their friends and family's feedback on the headlines. It gets passionate out there. People that are sort of taking this seriously think that people who are oftentimes using data and coming to different conclusions are killers, are careless, are intentionally harming people, are and the other side is true, true too. And we're living in this almost civil war of consciousness. People become very passionately focused. We're dealing obviously with a topic that has to do with lives. I lost a family member due to COVID. They had a funeral on Zoom. We're living in these new times. That's really, I guess, what this program is all about. I know it's what your intention is to give people the ability to put the headlines aside and really, as we're doing right here, right now, saying, here's the headline, and here's the study that headline is based on, and here's the data and what it means, because headlines sell papers, data is data, and it requires some thinking. Is there a way to sort of give people the ability to start learning how to filter, how to look at a headline and not just immediately go, oh my God, see, this fits my belief and I should share this with everyone? Is there some system or way that we should be learning to go, headline, pause, research, look at this, look at the study behind it, and maybe have a touch more skepticism for our own points of view before we just eat up everything that supports our current perspectives, and make sure everybody understands that if you don't believe with me, you're wrong and maybe even cruel?
So that segues into our next topic, the IHME model. So I go to this website quite a bit. It's the Institute for Health Metrics and Evaluation at the University of Washington. And I'll go here when I first hear of the most common panic porn these days, which is there's Armageddon in Florida, there's Armageddon in Arizona, there's Armageddon in Texas. 48 states are showing increases in cases, all of that stuff. And I go here to try to get grounded in what's real. So we have here COVID-19 projections for the state of Colorado. That's the one I have up. That's where I am. And if you go down to, this is the one I really like to look at, the hospital resource use. This is a great one because, as an example here for Colorado, you can see that there's this line down here, ICU beds available. So you can see that, and the blue line down here is ICU beds needed. So at its worst in our pandemic was April 19th. We had about 229 ICU beds that were needed, and we had 555 available. So we never really even came close to maxing out our ICU beds. Now, if we move this line forward to where we are here now in mid-July, looks pretty darn good here. I mean, we still have our same 555 beds. We're only using 30 beds of those right now. And if you even go to the maximum number that might be needed, we're only at about 60 beds. So, pretty good in Colorado. Now let's go to sort of the opposite. Let's go now to Arizona, because they've been in the headlines. So now we're going to switch this, and we're going to see something a little different here. If you can see beds available in the state is 500, and so you can see here that they're at around 300 hospital beds or ICU beds needed, maximum 407, and they've got 508. So as things progress in Arizona right now and over the next week or two, they could be in a situation where ICU beds get tight, certainly in certain areas, because the entire state could need 407 and they have 500. So Arizona is a little worse off right now. So let's go to Florida. Florida is another one that you hear constantly is Armageddon. And if we go to Florida, again, we can see that line of ICU beds available going all the way across the blue line here. And really, so at no point, they've got 1,600, almost 1,700 ICU beds as we go across. We're not seeing anything that looks like Florida is going to run out of ICU beds anytime soon. Now, notice that the maximum side of the projection can go up to 3,000 beds. So it's possible that sometime by the fall, Florida could run out of ICU beds. But if you look at the median projection there, it's unlikely they're going to run out anytime soon. So Florida is worse off than Colorado, but not nearly as bad as Arizona. Then you can go to Texas and get a better sense of that state, because it's another one that we keep hearing about time and time again, because that's all those Texans down there with their guns and their pickup trucks and all that stuff. So that there must be evil things happening in Texas. So again, if you go to ICU beds here, I'm having to look around my little light here. So 2260 ICU beds, and at the worst, they're projected to need around 1,400, could go up to 3,000. So they're more similar to Florida. It's unlikely they're going to run out of ICU beds anytime soon. So these are the kind of things I do all the time. When I see one of these headlines, I'll go to the IHME model and take a look. Because one of the things we're seeing in these states, and you have to be careful with this, is the hospitals have figured out from the first wave that if they report back to the state, let's say a hospital has 50 ICU beds, but they don't want 50 COVID patients in those beds. I'm just here to tell you that that's not how they would like to utilize their beds. So maybe they'll report to the state that they've got 20 COVID beds that are available, but they still have 50 ICU beds. So if push comes to shove, they can use those. And that's what the IHME model is based on, the total number of beds that are available in the state, not the total number that the hospitals are willing to use for COVID-19. So this is a good practice to do. You see a crazy headline, go to this and check it out and see what's real and what's not real. Get a sense for where someone sits. So we have Colorado being very low over here, Texas and Florida being in the middle, and Arizona being towards the top end.
If I saw that data correctly, it looked like on the Florida data between October and November, it appeared as if, you want to bring that up, it appears as if it would get significantly higher than what appears to be that ICU bed line. And my question really is, right, that purple line there, between October and November, it seems to get much higher than that static ICU bed line. But my question is, we're in July.
Yeah, I think you're looking at all. So there's the two lines there.
Yep.
The bottom dotted line is the ICU beds, and then the next line above that is hospital beds.
Okay. Okay. And it says the purple line says all beds needed, current projection. Um, am I seeing that right? The purple
Yeah,
line
all
appears to
beds
be
needed
above
current projection would be just above 3,000 with 20,000 beds available.
with
Uh,
20,000 beds. Okay, I'm looking at the line below that, ICU beds
the
available.
line yeah, the line below that is ICU beds that are needed
Got it.
versus so I think again, so if you look at ICU beds needed, they have 1,233 there against 1,600 ICU beds that are available. And then the next one is talking about ventilators. So listen, now you can go to the maximum of those and see that it's possible that we could be up to 3,000 beds needed there, and that may exceed the amounts that they have. But the good news is that over this summer period where we can make some decisions about what to do in Florida, they're not anywhere close to a maxed out ICU capacity.
That's the essence of my question is, data is then forecasted out. And if there's an error in data or if something changes between now and then, that data then gets changed later on. So these are all projections.
Yes.
They're not certain realities. So you don't look at the picture and go, see, it's going to be worse. You go, the projection is it might be, and therefore there's ways that we have to then make decisions. Is that accurate, how to think about it?
Yeah, correct. So the bottom line is at the end of the day, the farther you look at any model, including this one, out into October and November, you're getting into big guesswork land. What's going to happen over the next 2 weeks is a little bit more predictable. Over the next 4 weeks, a little bit less predictable. A little over the next 8 weeks, even less predictable, etc. So this is a good thing to look at to get a sense of what's going to happen kind of over the rest of the summer. And then what's going to happen in the fall, obviously, will be updated. But that's why I check this most days, just to see where things are. When I see a headline about, Florida is Armageddon right now, they've got them stacked up in the ER because they don't have enough ICU beds. And then I look at this and get a sense, a dose of reality of where things are. Now, that doesn't mean that there aren't places in Florida where they have more cases than they can deal with. But Florida is a big state. So obviously, patients from Miami can be moved to other parts of the state, et cetera.
I guess as we sort of come to a close, the question is, what do we do about it? How do we think about it? What are the takeaways? How do we avoid? Do we get fearful that there's more cases? Do we get excited? Okay, we're closer to herd immunity and we're getting to the other side of this. How do we interpret this? And knowing people are going to put in their political agendas and their perspectives and their previous history and so on. But ultimately, this program is about sort of laying out fact and fiction so that people can make the right decision. So today, what's our takeaway?
Yeah, I think the takeaway, Jason, is listen, when you see a headline, research first and react second. So it's research and react, not react. And I think that's the problem right now, is that we have become conditioned to react to the headline. In fact, that's what the people that write the headlines want you to do. I would recommend that you research the headline first before you react, and then you can react. Obviously, if you research the headline for Arizona and say, Arizona is getting really tight on ICU beds, I am going to be concerned about that one. Whereas if a headline comes out tomorrow, and I've seen them here locally, Colorado has having increase in coronavirus cases. And then you look at this model for Colorado and you're like, Colorado is actually one of the more tame states right now in the union. It's an absolute placid place compared to other places. So again, research and then appropriately react. Don't react just because you see the headline.
Yeah, well, It's going to be fascinating. And again, our only agenda is to, read the headlines, analyze the headlines, as all of us should, and then look at the data, look at the numbers. Is it fact? Is it fiction? What does it mean? How do we change our mindset and our lifestyles and our activities because of the data? And understand we are all learning. The scientists are learning, the statisticians, the doctors, people, and that I guess if there's any common denominator to all of this, from my curious side of things, is that maybe we should just sort of all focus more on the data and less on our agenda. And ultimately, I think that the safe way to go with all of this might be to be just more kind and understanding. That if somebody doesn't believe what you believe, that doesn't mean they're dead wrong. It just means that they may be looking at information and maybe even data that is different than the headlines you are limiting your perspective to on either side of the aisle. So we're going to do our best to make it sure it is clear to all of you that we're focused on the data, not the politics, not the agendas, not the craziness, but where does the data take us? Join us each and every week so you can go on this journey with us. We encourage your feedback, we encourage your questions, but please make them curious questions as opposed to statements that are there to push your agenda or your beliefs. That's not what this program is all about. This is a research-based, science-based program. Dr. Centeno, closing comments.
Yeah, please share this with everyone you know. We all have people who are dealing with COVID-19 in one way or the other. And so share it because, again, our goal is to follow the data where the data leads. Oftentimes that's against, a certain media narrative. Doesn't matter to us whether or not it's, news station A, B, C, or D that's taken it because they didn't really do their homework. It's all about us doing the homework for you, so share this.
Time will tell us, see how this all unfolds, but between now and then, we'll keep doing our best to find the facts versus the fiction. If you've got sources of data or information you'd like to share, leave them down in the comments below. We'll be observing and watching everything. We thank you for your contribution. We hope you enjoy the program. We hope you'll share it. On behalf of Dr. Chris Centeno, I'm Dr. Jason Deitch. Thank you so much for watching.
Thank you.